This breakout is changing the game in cancer through diversity partnerships. And I am pleased today to, one, introduce Dr. Otis Brawley to you. Many of you already know, but today we will be discussing health is more influenced by behaviors and social issues versus and access to quality food choices than by medical care. So cancer rates reflect that disparity. Blacks certainly have a 14% higher cancer death rate than non-Hispanic whites, and the highest death rate and shortest survival of any racial ethnic group in the U.S. for a majority of cancers. Strong, bold partnerships are needed to influence and support change. Dr. Brawley has been an advocate for such change his entire career. And so we're very fortunate to have him here today with us. He's also working with the CEO Roundtable as an advisor to our Gold Standard Committee, which is addressing health equity as well. Dr. Brawley, I'm going to give you a little bit of background on him. I can only give you a little because we only have 30 minutes, but he is an outstanding individual. He's a member of the National Academy of Medicine and a Bloomberg Distinguished Professor at Johns Hopkins University, who leads a broad interdisciplinary research effort on cancer health disparities. Dr. Brawley is a medical oncologist and epidemiologist. He serves as a Bloomberg Distinguished Professor in Department of Oncology of the School of Medicine and Department of Epidemiology on the Bloomberg School of Public Health at Johns Hopkins. He is also a member of the National Cancer Institute Board of Scientific Advisors. And for many, Dr. Brawley, for the world, he is known, and in the U.S. And around the halls of oncology, to many he is known as America's oncologist. Dr. Brawley, we welcome you to the floor today, the camera today, and we gladly hear you. I turn the mic to you.
Thank you. Thank you so much for that introduction. If we can bring up my first slide. Well, let me start out and then maybe we can catch up. My first couple of slides just tell you that I'm a professor at Hopkins and I practice medical oncology and I do epidemiology, which is looking at trends and numbers in the population. I want to tell you my disclosures, which is I do some consulting for the U.S. government for the National Institutes of Health and Centers for Disease Control, as well as I do some consulting for Genentech. What I want to talk to you about over the next 15 minutes or so are trends in cancer death rate over the past decades, define race and population, define disparities in the United States, and then discuss some of the approaches to them. Interestingly, heart disease kills about 650,000 Americans per year, cancer about 600,000. As all of you know, coronavirus has now surpassed 200,000 deaths this year. It will be, it's unusual, a disease that none of us knew existed at the beginning of the year is going to be the third leading cause of death in the United States this year. Cancer at 600,000. Cancer death rates have been declining over the last 30 years, going back to 1990 is the peak year for cancer death rates in the United States. And there's been a 29% decline for all populations. Now think of a 29% decline as the risk of an individual of any given age dying today is 71% what it was for someone of that age in 1990. And there's been declines in all races and ethnic groups. African Americans had the highest death rates and have had the highest decline, or the fastest declines, but the death rate for African Americans is still higher than the death rate for white Americans in the United States. And I should point out, white Americans have a death rate higher than that of Native Americans, Asians, and Hispanics. Wise early detection, especially of colorectal, breast, and cervix cancer, is the part of the reason for the 29% decline, as is improvement in cancer treatment and prevention of disease, something we really want to focus on a lot. Going to slide 10 now. Slide 10, if the audience can see it, details the major causes of cancer in the United States. Most importantly, 33% of all cancers are due to smoking. The conditions of overweight and obesity is 20% of all cancers. Diet is 5%, and lack of exercise, 5%. So energy balance, which is really the combination of too many calories, not enough exercise, and obesity, sums up to 30% of all cancers. And most people don't realize that it is the second leading cause of cancer. And we think of it as a three-legged stool: too many calories, not enough exercise to burn them off, and then obesity. It becomes literally the second leading cause of cancer right now. And with the declines in smoking over the last 40 years, it is destined to become the leading cause of cancer by 2030. Now, the next slide, if you can see it, is smoking rates. Smoking, of course, causes cancer. And I just put this slide in to note that as people become more educated, they are less likely to smoke. 4.1% of people with a graduate degree versus 23% of high school dropouts. And yes, people who have GEDs, about 37% smoke. Smoking is something that we can control. Taxation, smoking cessation programs, all should be encouraged. Next slide is a slide looking at obesity in the United States versus a number of other countries. And this is just a way of noting that the United States is the most obese country in the world. And it started in 1970 and took off, and we're now over 35% of American adults is obese. And as we move to the next slide, you can see the rise in non-Hispanic Black women is greater than the rise in any other racial or ethnic group. And indeed, now about 60% of adult females are adult Black females are obese. If one adds the overweight, which is an additional category, not as bad as obese, it's 80% of adult Black women are obese or overweight. Among white women, it's about 60% are obese or overweight. Going to the next slide, it lists the number of breast cancers diagnosed and number of deaths last year. 269 diagnosed, 42,000 or so deaths last year. And there's been a 40% decline in risk of breast cancer death since 1990. That means that a woman of any given age, say a 55-year-old, today, her risk of dying from breast cancer is about 60% of what it was in 1990. Now, screening is about 40% of that decline. Improvements in treatment, 50 to 60% of that decline. And importantly, there are 7 states in the United States where there's no Black-white difference in breast cancer death rates. Black women and white women have the same death rate in 7 different states. This really tells us it's a problem of getting services to people, screening as well as treatment. And slide 16 shows you a map of the United States. And the dark blue states are where we've had a 44 to 51% decline in the death rate since 1990. I noted earlier it's 40% decline for the US as a whole, but it's 51% in Massachusetts. And the purple states are states where we've only had a 20 to 29% decline. It's 20% decline in Mississippi, 51% decline in Massachusetts. They started at about the same place in 1990, and now we've had dramatic declines. Moving on to talk about colon cancer, about 145,000 will be diagnosed with colorectal cancer in a given year, and 51,000 or so will die. We've had a 50% decline, a halving in the death rate from colorectal cancer since 1980. And now as we go on to slide 19, you can see we've had a 50% decline in the United States as a whole, but it's up to a 63% decline up in the Northeast And some states in the South, like Louisiana, 12% decline. So when we talk about disparities, we used to talk about racial disparities. More and more, we're talking about socioeconomic disparities, and even more and more, we're starting to talk about state by state disparities. Lung cancer is the #1 killer of people in the United States, and slide 20 is death rate by state, death rate from lung cancer by state. And you can see in the very dark red states, again in the South primarily, are the states that have the highest death rates from lung cancer. The very light states, California, Utah, Colorado, and New Mexico, are the states that have the lowest death rates from lung cancer. Again, huge disparities. And then we go to slide 22. The orange states are slides that have not expanded Medicaid under the Affordable Care Act. These are states where adults, people age 18 to 65, have no access to health insurance except through employment or buying a private policy. People in the blue states who are very poor, who are adults, can qualify for Medicaid and get access health insurance there. And you'll note that the states in the South where we had the worst problems from breast and colorectal cancer, the least progress, are the states that have not expanded Medicaid. That's they're actually not related, but they're related. There's just not as much interest in healthcare in the South. The expansion of Medicaid really began in 2010, and many of these patterns, as I pointed out, go back into the 1980s and 1990s. Summing up, going to slide 23, just want to figure out who are the disparate populations for cancer, and where do they live, and what's the actual numbers. Of the 600,000 or so who are going to die from cancer this year, we've figured out that about 22% of them, 132,000, would not die if everybody got access to everything that's currently available: prevention, screening, and treatment. And so what we're really saying is the disparate population in the United States for cancer is 132,000 people. Interestingly, 80,000 of the 132,000 are white Americans. They tend to live more in the South than in the Northeast, but they live in virtually every state in the United States. And the issue of health disparities is not just a racial minority issue, it's really a socioeconomic and education issue. Slide 24 really sums up my philosophy. How can we provide adequate, high quality care to include preventive services to populations that so often don't receive them is really, really important. And in the future, if we continue to have an Affordable Care Act, state by state disparities will increase. The Northeast will get better as the South gets worse. And on slide 25, really to sum everything up, the cancer control focus should be on disease prevention, smoking, diet and exercise, alcohol avoidance, vaccination, hepatitis and HPV vaccination especially. And getting optimal basic care to all people is incredibly important. Appropriate screening, appropriate treatment. And please note that 130,000 lives a year that could be saved, that's without any new science, that's without any new technology, except the technology of getting what we already have to everyone who needs it. And my last slide is just the difference between equality and equity. There are certain populations, I would argue Appalachian populations, for example, who are going to need a little bit more to get where we all want. We don't want equality where everybody gets the same thing. We want equity where everybody gets what they need to get where we all want to get. And I'll stop at that point. Thank you.
Dr. Brawley, that was the fastest execution of slides I've ever seen before. Tremendous content and seamless execution. So we're going to go ahead and jump into some questions, and I have some in the queue for you as read, and we can go ahead and begin with that if you're good with that.
Sure.
Okay. If you feel like during this time that I'm asking a question, you want to revisit something you've already stated, please feel free to go back to that or anything along those lines. Just a refresher for those that are in the box with us, if you scroll to the bottom of your screen and you actually want to submit a question, all you need to do is look at the bottom panel and you click the light bulb, and that will give you the opportunity to do that. Super. Okay. So I am going to go ahead and shift some over to you here, Dr. Brawley. What disparities are most concerning to you?
The disparities that are most concerning to me are the disparities that we could actually fix. And they are generally disparities in treatment of breast cancer, disparities in treatment of colon cancer. There's so much focus on screen. In breast cancer, for example, we've actually been able to look at the 45,000 or so women who die from breast cancer every year and realize that about a quarter to a third of those deaths could have been avoided. And the reason why those deaths occurred is failure to get adequate treatment after diagnosis, far more so than failure to screen. So I would say treatment of breast and colon cancer are my real two biggies. And then the disparities in lung cancer, which are all socioeconomic now. The black-white disparities in lung cancer are starting to go away because it's an interesting phenomenon that Black children are not smoking. Younger Black people are not smoking, but younger whites are.
Could you repeat that again?
Yeah. The black-white disparities in lung cancer are starting to go away totally. And the problem with smoking has become much more a young white person problem than a young Black person problem. There's still a problem in the Black community and work to be done in the Black community, but the prevalences of cigarette smoking among young white children, and this has been going on for about 20 years, are much more significant than in the Black community.
Okay. Another question. Thanks for the great presentation. The person just said, I believe they're a friend of yours, Jen Mills. I'll relay that to you with Foundation Medicine. Can you say more about what's on your mind about widening the disparities gap in the era of personalized medicine?
Yeah, that is going to be a concern. As we get to personalized medicine is really looking at specific genetic markers and having drugs that are targeted at specific genetic mutations. What you really need to do is do studies to look at various populations and those markers in those populations to make sure they're there. You know, for example, if a white person or a Black person has estrogen receptor positive breast cancer, that's one of the first markers we ever had, and that's the beginning of precision medicine. Tamoxifen works in both of them. But I want to know what is the estrogen, what proportion of various populations have estrogen receptor positive disease versus estrogen receptor negative disease. And while we're on that point, I hate black-white. I actually would note that when we talk about Asians, we can accept that Filipinos, Japanese, Koreans, Chinese, and Indians are all very distinctly different groups. When we talk about Blacks or Africans, we don't accept that Togo, Benin, Ghana are all very different groups. And by the way, those are all populations that are common in the United States among African Americans. We also have to worry about admixture, the fact that groups have intermarried and mixed up. But I'm very concerned that we need a large number of people of all races and backgrounds in our studies having to do with precision medicine and various markers for cancer. Very good question. I could spend an hour answering that question.
And we could spend an hour listening to you. So, okay, next question is, what do you predict will happen in the event that the Affordable Care Act is eliminated?
If the Affordable Care Act is eliminated, we already have evidence that we're going to regress in terms of cancer death rates, heart disease death rates, diabetes death rates. There's going to be a lot of suffering out there and a lot of people needlessly dying. We're also going to have increased problems in supporting some of our hospitals that were already starting to falter financially. So we're headed toward a disaster if the Affordable Care Act goes away and something like it does not replace it. I'm not necessarily as much pro-Affordable Care Act as I am pro-programs to get human beings the health care that all human beings ought to be able to get.
So that segues right into our next question, and the gap feels really big and difficult to address. Are you encouraged or discouraged at our progress and the chance of making a difference now?
I am, well, I'm a medical oncologist, so I'm always an optimist, but there's a number of things that do discourage me. It discourages me that I've made a career off of publishing papers that show that people in one part of the country are dying unnecessarily, or that programs that are implemented in another part of the country are actually saving lives, and there are people whose lives are not being saved. That's really discouraging. I'm optimistic that we know a great deal about oncology and cancer, and if we could just get society toward implementing those things, we could save a lot of lives. Some of the work that we're doing nowadays, by the way, shows that the Europeans and the Canadians actually save a lot more lives from cancer than we do in the United States. We do not do as well as people in Western Europe or people in Canada in terms of saving lives. We think we do, but we don't.
So I'm going to add in a little bit of color here, and I know that you've worked with us some on this project as we're beginning to move it forward, but we look forward to sharing in our future series more about the Historically Black College and University opportunity that I think will help to address that gap of what is communication, trust, breaking down some barriers around prevention and early detection for our next generation, as well as them messaging back and forth. So we look forward to sharing that. I still have some more questions. Okay.
You bring up a very important point, and that is a large part of what the Western Europeans and Canadians have done better than us are the preventive things. Even though when I go to Europe, it seems like everybody's smoking, they have less lung cancer deaths. But the prevention, the diet and exercise part, the lack of obesity part is really important. Go ahead, I'm sorry.
Okay, fantastic, thank you. So that's a critical part that we'll need to make sure we do incorporate it into that HBCU initiative, is around health and wellness around nutrition. Diet and nutrition is as critical as element 2. Another question, how can pharmaceutical companies help to create more equity and better cancer care outcomes?
That's a really difficult question for me to answer.
That's why I gave it to you, because I knew you would like that one.
Things that I've seen pharmaceutical companies do that I thought were net beneficial was work with hospitals, work with clinics and healthcare providers to try to establish programs for education regarding patients getting care. When patients are educated, I think that's better all around, and hospitals can't really afford those sorts of things. I've seen some drug companies actually come in with various programs for that sort of thing. In the treatment arena that I live in, a huge problem is transportation. I've yet to see a drug company be willing to help pay for transportation and other aspects of care. There, I've seen drug companies discount drugs so that people could afford them. I'm appreciative for that.
Okay, so I'm going to ask you, I'm going to break this question down into several. So we're going to start with the first part of it. What is the impact of pollution and other external issues with cancer?
Well, pollution is certainly a cause of cancer. There was a slide that I had in my deck where pollution showed up. By the way, medical radiation from too many screening tests and too many imaging tests was on that same slide, right about at the level of pollution. Pollution is certainly a problem. Pollution is a bigger problem in certain areas of the United States than in other areas. For example, some of our inner cities where there's been lead and heavy metal contamination from old factories. Of course, smoke is carcinogenic. All of those things are very, very bad for cancer, and we really do need to focus on those things, but it's one of many. The big issues, though, for cancer are tobacco, which is a form of pollution, and energy balance.
Great. The second part of that question is, how can artificial intelligence and deep learning support cultural impact and access to care and education?
Wow, that's a big one. You know, one of the biggest issues, and this is an amazing thing in huge hospitals, and this is I'm heavily in the prevention of disease, and we'll get to that in a second, but in the issue of giving people care, there's a lot of people who fall out of care, adherence and compliance, things that we in medicine just don't realize. Mrs. So-and-so stopped coming to the doctor or stopped getting her care. Our computer health records actually could be programmed to let us know that this is a problem, and we don't do that enough. In terms of prevention, diet, and exercise and IT, that's above my pay grade. We need somebody smarter than me to address that, but I'm sure there's some answers there.
Great. So I know that you were hopping between meetings, and we did go over a little bit, but we also got a late start. So technically we're in our window. I know that you have to hop back to a meeting, but before we do that, I want to just let you wrap a bit on what do you think is a next best step specifically for our audience, which is made up of members and special guests, where we can actually lean in with you in support of these issues. And you know some of the work that we're doing already, so I'll ask you just to combine that with your thoughts.
Sure. Well, I frequently am asked, what do I think about healthcare reform? And I tell people we need to not reform healthcare. We need to transform healthcare. We need to change how we actually consume healthcare. We need to change how we provide it. We need to respect science and do things in a very scientific way. We also need to worry about our fellow man and worry about people who are not getting adequate care. And those are the things that I would really focus on. Individually, we'll all need to worry about prevention of disease more so than we currently do. 5 to 9 servings of fruits and vegetables per day, as well as exercise, trying to stay lean. Those are all very, very important things for preventing cancer, heart disease, and diabetes. And that's where I would start.
Fantastic. Number one, thank you so much, Dr. Brawley, for your insight, your guidance, and your always profound, genuine willingness to help another, help a survivor, help a patient. And I know that from you to be true in your daily walk of life. So thank you for being America's oncologist. And thank you for also helping us with the roundtable. Just a couple of things, housekeeping here for us. Dr. Brawley's presentation has been recorded. It will be available on our conference website for 30 days. He will also be sharing his deck with us so that you may actually go in and look at that deck in the library at your leisure. And again, also highlight, as we mentioned earlier in other sessions, I want to highlight we have an upcoming series that will follow in Q4 and Q1 that will follow on some of the content here that will be addressing the HBCU initiative and launch, gold standard implementation, accelerating clinical trials, participation and access, and creating a well-being environment. We hope that you will enjoy the quick break and you will reconvene in approximately 10 minutes. And also you will also be receiving an email tomorrow from us for a survey. We hope that you will take that. Thank you for joining us. Thank you again, Dr. Brawley. And equality versus equity. Equity is a good one. Thank you.
Take care. Bye-bye.
Yes.